So just a little bit about our organization so you can tell from size. We are still a privately owned, independent, regional integrated healthcare system. We're in Southeast Iowa. We also cover Western Illinois. Our main service is Des Moines County in Southeast Iowa. You can kind of see there the size of our facility. So we're not large, but we take good care of the people in our delivery area. This is what our campus looks like, if it will advance.
Yeah, you did.
Okay, awesome. So that's just a picture of our entrance. On the right side is our clinics. On the left side is the hospital facility. So this morning, we were going to discuss a few learning objectives. Oops. This is like going backwards. There we go. Okay, so we're going to talk a little bit about our journey at Great River Health Systems, lessons learned, and share our success story. So we began with the education for the team. We did attend in February of 2016 the Candor Review Process Leader Retreat at Stanford University. Dr. McCoy, myself, and Ann Martin attended that, and we learned a lot from Dr. Tim McDonald and Richard Boothman and their team out there. We also researched a lot of articles, websites, and the toolkit from the AHRQ came out in late March, early April. And so they kept talking about it at this conference, and it finally came out. And that was something that helped jumpstart us. Okay.
I'll do this while you're doing it.
Okay. I just
Passed Candor legislation, 135P in the Iowa Code, effective April 14th of 2015, or passed it April 14th, 2015, effective July 1st of that year. The definition of provider that is covered in the Candor legislation was expanded last year to encompass virtually all providers now. The legislation provides some opportunity for healthcare providers to have a conversation with patients who agree to participate in a Candor program about objective outcomes that are leading to death or serious injury to patients. And they can have this conversation in a confidential manner. That is, anything that is discussed in the conversation cannot be used in later litigation or is not discoverable. So that if you enter into a Candor conversation and for some reason the patient says, I'm done, or even a provider says, I'm done, and litigation follows, what was discussed in that Candor conversation is not discoverable. If there is a conversation, patients are told that this is confidential. You have a right to have an attorney with you if you wish. You can have other people in with you, but they are also subject to the confidentiality. The provider, in anticipation of the Candor conversation, typically is going to do some sort of investigation. What actually happened, if it truly can be defined. They can disclose the results of that investigation in the Candor conversation. It's open conversation, and it's also open conversation about what might be done in the future to avoid this sort of error or event or whatever occurred. There can be a conversation about compensation. So typically what we have done is we've had a preliminary conversation with patient family. That kind of then rolls into a discussion about the compensation for the case. Again, everything that is said is confidential. This is all physician or provider driven. The provider has to agree to start the process, and then we just kind of roll with it. We've had a number of cases. All of them have worked out, I think, well to the satisfaction of patients. Many of them have had attorneys. In fact, all of them have had attorneys represent them, and the process has worked very well for us.
Okay, so our Candor process, we didn't go with the flow chart. We went more with the arrows and just identified the phases where we identify the event, we activate our system, we have response and disclosure, investigation analysis, and resolution. And when we have an unexpected harm, it could be physical, emotional, or financial to the patient. The financial one seems to come out with a lot of questions during that initial disclosure with them. So to implement this at Great River, we decided we needed to have different teams that would lead this and talk to each other. We put together all of us to start the implementation. What do we want it to look like? Who should be involved? What kind of training do we need to do? Who do we need to speak to in the organization? And so we met kind of regularly for that. Then for each of these teams, we put a lead person. So the communication team is Heather Nelson. Our event reporting, investigation, analysis team is Ann Martin. Resolution is Liz. Disclosure is Heather. And really that's more, she's organizing the disclosure events. And then care for the caregivers, Dr. McCoy, and then Teresa Colgan for nursing. So for the education, our initial team formed kind of our structure. We started to adopt a policy. We did presentations to our board of directors, our medical staff at their service meetings, their medical practice committee, medical executive committee, quarterly medical staff meetings, and then at the hospital staff level, we started with the leadership team, so directors, managers, supervisors, and we've kind of talked about it frequently for several months to start with. We have not done a full-blown education to the staff level, but we have done it with all the leadership team. Okay.
In addition to working with people in-house, when we started this process, one of the first people I contacted was our med-mal carriers representative who had not heard about the Candor process in Iowa. I provided copies of Iowa Code 135P and some of the other information that we had assembled at Great River. Our carrier wanted to review the material and has seemingly wholeheartedly embraced the Candor process. In fact, from time to time, the representative is asking us, hey, is this a good case for your Candor process? After I had buy-in from our insurance carrier, I contacted the defense attorneys that we routinely use in our cases. And as I'll explain a little later, I also reached out to a plaintiff attorney who had contacted me to see if she would be interested in participating in a Candor process.
Hello. So, in addition to me being the corporate compliance officer, I'm also the patient safety officer. So, when we maybe have an event that might occur, I might be the first initial contact. So I might get a phone call, I might get an incident report, especially if it happened over the weekend. And so I usually will implement the team then. Heather might get that phone call as well first, so that might be how it starts. Once that phone call comes in, I reach out to our team to let them know that we have a possible Candor case or a CRP case, and we want to get that conversation going. So we might go up to the floor and we start with the staff right away, getting that what happened. If it's a nurse that's had maybe made the error, we would have our VP of nursing connect with that nurse to right away allow that support. If it is a provider that it might occur, that might happen to, then Dr. McCoy will actually start that conversation with the provider. So we'll meet with that patient right away, whether it be Heather and myself or the provider having that initial conversation with the patient, just letting them be able to talk or seeing what they know, and then just reassuring them that we are going to look into it and get back to them, and maybe Heather can add on to that. Yes.
So when we first started, we did pull that AHRQ toolkit and went through step by step through that, multiple confidentiality statements, things like that. But when something does happen, Dr. McCoy and I in the past have, if we're notified immediately of it, we go up and we talk to that patient and that family right then and there as soon as we can. Sometimes we don't have answers. We tell them, once we do have the answers for you, we'll be open, honest, and tell you everything, we know. So I think that's the main thing, getting up there, talking to them on the floor, and then Ann doing the investigating and the root cause analysis, and just keeping in contact with them.
I think as Dr. McDonald pointed out, as soon as possible, trying to get up and start communication and let them know we're there, we're going to take care of them, we're not going anywhere, we don't have all the answers, but we'll get them, and so that they know the process is there and they're not just kind of wondering what's going on. So that's vital. That's probably the most important thing. And one of the things, and we'll get into this maybe a little bit, there is a lot of preparation that goes into this. A bad disclosure is probably worse than not one at all. So sort of knowing the staff, how well they're going to interact or not interact, having some coaching ahead of time, preparing them for what's going to happen, that's huge because it could go bad really fast. So.
Yeah, I was just going to add to that with the disclosures. A lot of times, the providers know it when the event happened, especially surgical ones, way before our team knows. So one of the things that we've kind of learned early on is at least we have a secure texting messaging system in our organization. So we've created a Candor group in that, and we're still continually educating providers and staff to utilize that to notify us right away. But there are times that we have to go back in after a disclosure by a surgeon and let's do a redo before they leave the recovery unit.
Yes.
At what point do you invite the counsel for the patient to come in the room?
Typically, it hasn't been while they're a patient in the hospital because they usually get invited closer to the resolution. Sorry.
We try to deal with the clinical things and the patient's needs. That stuff will come later, typically. Mm-hmm. We let them know it will come if necessary, but.
Would you please be careful to repeat the question before you answer?
Oh, sure.
I'm sorry.
Sure.
So the question was, when do you invite legal counsel into the room?
For the patient.
For the patient,
Mm-hmm.
yes.
You said this is confidential protected information under the Candor program, whatever you want to call it. When is that conversation that you say, can this be a Candor situation, and then where does that fall into the disclosure of what happens with the event?
Right. So, yeah, that was one of the things when Ian said that about CRP, communication and resolution versus Candor. That's very confusing at first. You don't know. You haven't done that investigation. So we treat all of them as we're going to say we're working on this process. We will get you answers making that contact, but we don't bring in papers for Candor that first day.
Every unanticipated outcome or a need for a possible process improvement, it can be a CRP event. And we're going to go tell them what we know when we know it and be honest and open and get information. Some of those will involve the Candor and the Candor legislation. Some of them, it's not necessary.
And when you're in the room with that patient, we just say, we're gonna look into this. You let them talk about how they're feeling, what happened. We don't have the answers yet. We're gonna look into this for you. They'll get, Heather will provide them their contact. She'll stay in that contact, call me anytime, stay in that constant contact with that patient while myself and a group are doing that root cause analysis and getting all the pieces together within that 72-hour time frame. So as we, our plan was once we had the training and provided the education was to implement July of 16, but kind of right around shortly after we got that training, we had a case come to our, it was a medical event that come to us the first part of April, and so we got going right off the get-go, and that was right away April 1st. So I'm going to let Liz kind of go into to the next one that she got in April.
At the end of April of 2016, I had a phone call from an attorney who was kind of giving me a heads up, hey, I have a client here who had an event at Great River, and do you want to talk about it? And usually when I get the calls from this attorney, we end up in some sort of mediation. But I said, I need some time to see what's going on. I'll call you back. And I talked to the Candor group. The incident involved a surgeon who indeed had a unexpected serious outcome for a patient. The physician felt terrible. He acknowledged that, yes, he had an error. He wanted to talk to the patient, wanted to talk to the family. And we looked at this as a perfect opportunity to try the Candor event for the first time. Insurance company was on board, talked to the plaintiff's attorney, and suggested that we try the Candor process. Wasn't too sure, wanted to do a little looking herself for what the Candor process might involve. Called back and said, yeah, we'll give it a try. We went through that process. It gave the surgeon an opportunity to explain there was an error. Gave the surgeon an opportunity to apologize and reconnect with the patient and family. There was a resolution, a financial resolution that was satisfactory to all of the parties. And I think both surgeon and patient walked away from that experience satisfied. Yes, there was an error, but they understand what the error was. It was unintentional. This is what we're going to try to do to make sure this doesn't happen again. And there was that person-to-person connection that was so critically important.
I think what I'd add to that too is the patient was a young patient and just had a lot of questions like, what does this mean in my future? And so that gave them a lot of time to have plans. Here's other physicians because she had moved out of the area for work. And here's who you should get connections with and who you should be with. And it just really put her at ease. And she felt there was a plan for her for the future.
I have a question because it was a little kind of caught my attention when you said the plaintiff's attorney had reached out. I mean, to me, that's, falling in the definition more of a claim and also the, things that can trigger the reporting.
Well, it was more of a conversation at that point. There wasn't a claim. It's just kind of a heads up, guys.
Right.
This is going on. I'm not sure at that point that plaintiff's attorney had even seen the records, had just talked to the patient, and it was kind of a joint investigation. And then the process kind of turned into the conversation and then rolled into almost a mediation even before anything ever got filed. I mean, there was no written claim that was ever made. There was no suit that it was ever filed.
Once there's a written request for enumeration, then you can't start, yeah, exactly.
Was there a delay? Was there a reason? You obviously wanted to speak with the patient right off the bat, and it sounds like that had already happened.
Yes.
So the question was, why was there a delay? This was when we first got started. We weren't even really formed yet. This was something that had occurred that we weren't even really aware of.
Right. So the event
So-
actually happened in like December, and we didn't even receive training until February. So had no process.
We were kind of going backwards instead of forwards
Forward.
like we like to. Yeah.
I mean, this is,
And how did the plaintiff's attorney get wind of it? Just through the patient, or?
the patient talked to the plaintiff's attorney. Plaintiff's attorney was calling, hey, giving you a heads up here. Plaintiff's attorney wasn't even tuned on to the Candor process at all.
Because it seems like it's extremely new to like everyone.
Yes.
Yeah.
Very new, yeah.
It was very new. I see there's a question.
If someone goes through the Candor process for the practitioner, is this reportable to the national practitioner?
So the question is, if someone goes through the Candor process from a practitioner standpoint, is this reportable to the National Practitioner Data Bank? And no, it is not. Because there is no written request for remuneration. This is a verbal.
And then the other question, unrelated to that. Over my career, I've seen several attempts by plaintiffs' attorneys to break through the confidentiality of the peer review process. Has that occurred yet, or with any success in the Candor process?
So the question is, has there been any plaintiffs' attorneys that have attempted to break through the confidentiality of the peer process or the confidentiality of this process? Not that we're aware of, not yet, no.
Right.
I'm not saying it won't happen, but no, we haven't experienced
Yeah,
that.
the usual request from plaintiff attorney in the Candor cases has been for the medical records. They've not gone any farther than that.
Okay, so some benefits that we found in our organization with the Candor process is prior to us implementing this, it was always don't talk about it, don't tell anybody, don't talk about it outside the organization or your department. Now we have that prompt disclosure. We talk about it. We educate. It's within our group. It also didn't help change, before it didn't change any processes. So we could potentially make the same mistake over and over again. And now we have continuous process improvement. We've learned from it. We've made, based off of some of our cases, we've made some good organizational improvements and have not seen any more issues with that. So that's really helped us. There was always that deny and defend, I didn't do anything wrong, or it was their fault, like we talked about earlier. But now there's more of the transparency. We talk about it and say, it's my fault. I did it, but we don't blame. We also had the physician and nurse root cause. Now it's kind of focused on a just culture and human factors. So it's not just about, two people, it's about the whole organization. It's about, we severed relationships with our patients and our families, and now it's more about having that relationship maintained, and you'll find that out later when you meet our family. We've had, it takes longer, 3 to 4 years to have a resolution, dragging people through the system, and now we have that solved within a 6-month period. It saves heartache on both sides. And then our caregivers, is the other victim besides the patient and the family, and now we have that care for the caregiver. We have the VP of nursing supporting the nursing services, and we have Dr. McCoy that supports our provider services. So it has been really great for our facility.
And it's been really helpful because even cases that may not, cases that I'm not aware of because we didn't have a CRP event or something that happened, but Liz becomes aware of something, she'll give me a ones up and say, hey, Dr. So-and-so needs touched. So. This is weird.
So I am the communication piece, so I talk to patients every day on the phone or in person, every day, all day. But a lot of things that they want, they want to know. They want answers to their questions. They want the truth. They want you to be honest with them. They want somebody to feel like somebody's there for them, to support them, and kind of just stay with them through the whole process. So, I spend a lot of time with these people, a lot of time on the phone, talking to them, kind of helping them, giving them the answers I have, setting the meetings up. But that's what people want. They just want to know. A lot of times, I've been told, I love my doctor. I love my nurses. I don't want anything bad to happen to them, but I need answers.
You went to lessons learned. Okay. So for lessons learned, we would have liked to have had a different beginning because we wanted to have it with our plan in place, our policy in place, all the forms, but unfortunately events happen, patients need you, providers need you. So be prepared for that. And you're not going to have a perfect implementation that you dreamed of, but it does work and you still get the job done. Have that communication strategy for the response team. We didn't start with that Cortex message group, and we quickly learned we needed one because we didn't want all of us to have to activate and go, but we wanted to make sure who was going. So now we all reply to each other so we know who's going to go to the room, who's going to talk to the provider, and that's helped our team a lot. The other thing is train all team members equally. 3 of us got to go to the training in February, but not all of us. And so that is helpful if everybody's on the same level when you're working together. And then utilize the skills each team member brings. You talked about the communication skills, and so we always tell Heather she's our expert because she's great at just asking them questions. You know, what do you want? What are you looking for? And then she brings that back to the team so when they go into the room for the final disclosure with them. Mm-hmm.
I just have a quick question because you seem to be referring a fair amount of like hospital cases. Have
Yes.
you done like public cases or misdiagnosis or something?
Yes.
That you know, kind of
Right.
that?
You wanna
So
repeat?
the question is, these all seem to be hospital cases. Have we done any more clinic or ambulatory? I think, you know, a lot of times a lot of the unanticipated events that happen in the hospital. I think we have a lot better system at looking for those. But I've gotten a call from a clinic from a provider that says, I got a patient here and this happened elsewhere. You might want to call and talk to them. So there have been things that have been found later in an ambulatory setting that may have referred back to another provider or a hospital setting that then we've went back and dealt with.
Well, and actually our family that's coming at the end, it started in the clinic requiring a hospitalization. So that happens too.
I think we skipped.
We skipped one, but that's okay.
Okay. Oh, yes.
What we deliver. You want me to go back or stay with lessons learned?
Oh, yeah, well, they can see that. It's in the packet.
Yeah, okay. So the other thing with lesson learned is to investigate fully each case because it's easy for the team to get involved in a record review. And we all know that the record is not everything that happened. And sometimes you need to talk to the CNA. They know things that maybe the rest of the professionals were busy doing something else, but they were in talking to that patient at the time. And it's just really critical to get everybody's viewpoint because everybody sees an event differently. So that helps. And then lastly, I think lessons learned, we learned more today, is the patient communication consult service might be of benefit for us too, to help with the providers going in for that early disclosure.
So every time there's an event where we're going to have a provider that's going to go and discuss things with the patient, I usually try to meet with them, if at all possible, beforehand and kind of talk to them a little bit about, you know, for some this comes naturally. For some you sort of have to say, I want you to sit down and make eye contact, and I want you to try to, you know, show them you're sorry, because some people that's just not natural to them. And try to go over with them, here's what I would anticipate happening. There could be anger, there could be yelling, so that they sort of know what's coming. But the main thing we just try to tell them is, you know, tell them what you know when you know it, be honest. If they ask you a question, answer the question honestly. If we don't know the answer, tell them that. We'll get the information as fast as we can, or what we can get, and get back to them. And that's just really the bottom line. And you know, they taught us in training, it's really kind of intimidating, and it's sort of hard to get started. You say, well, how do you get started? And it's just like, you just do it. And once you do it, you sort of realize, well, that went pretty well, but you got to do the preparation ahead of time. But once you do it a few times, you're sort of like, okay, you see the results, and it's so much more rewarding. So.
And not all cases where we have internally talked about candor have the providers said, yeah, I think I'll do that. We've had a provider say, I don't want to get involved in the candor process. We also had a case recently where we had a conversation, or Heather had a conversation going with a patient. We suggested candor to them. We submitted to them. There's some forms that they fill out where they agree that the conversations will be confidential, and patient looked at those forms and said, no, I want to talk to my attorney. That doesn't mean that in the future, if we're contacted by the attorney, that we might not try the candor process again. But just because you're talking about candor doesn't mean everybody will accept the process.
And we have actually, when we've been to that place, we've had one case that didn't bring attorney in for the financial resolution, but we've had some that say we want an attorney, and we've actually said, well, here's somebody we've worked with before. So you can build that relationship with plaintiffs' attorneys that you know will work through this process.
And I think, honestly, most of the time, if you're going to have a resolution that's going to have a financial resolution to it, I think it's probably best to have them represented with an attorney, because the last thing you want is somebody to come back later and feel like somehow you duped me or something. You don't want that. That'll just ruin the whole program. So I think you want their best interest served, and they need to have an attorney present to make sure that happens. Mm-hmm. Yes.
So you would guide them and suggest that they would want to have an attorney if you're reaching a financial resolution?
So the question is, would we guide them to obtain an attorney? And the answer would be yes. Mm-hmm. So if we sit down with someone and we've obtained all the papers and we're all in agreement, we're going to have a candor meeting, we try to have the first meeting, if at all possible, be more clinical. We try to deal with the clinical part of it and get their questions answered and have the providers at that meeting that were involved. We try to have not too many people, but we want the patient to have enough family members to represent them, they feel supported. And then usually, ideally, it's a separate meeting, maybe however many it takes, but it would be at another meeting when you're talking about the resolution. But yeah, if we know this, there's sometimes, this is going to be a financial resolution, then we want them to get an attorney to be with them.
Have you had an experience where, well, sometimes a patient or family's expectation of what the compensation would be quite wildly different than what the case statistics would show that event would be worth?
I'll repeat the question, I'll let Liz answer. So the question is, are there times when the patient's expectations of a financial resolution may be a lot different than what our expectations of that resolution are?
As I mentioned earlier, when we start talking about the compensation, that's really it may be the same day, but it's kind of a different conversation with the patient. And we usually have our insurance rep, either in person or on the phone, who has analyzed the case, has a feel for the numbers. In the cases where we have had a plaintiff attorney there, it's typical mediation style where they're starting here and we're starting here, and the first number we throw out or they throw out is not the number where we settle. In the one case where we had a patient who came in without a physician, or without an attorney, they also had a higher expectation than what our first offer was. Again, the dollars are being essentially negotiated by our insurance rep, and he moved up. So I think we got to a point where everybody was satisfied for the dollars. I think in the case where the patient and husband came in without an attorney, they had done some research, and they had a pretty good idea of what the general ballpark settlement is in that type of case.
And she worked for an insurance company.
Yeah.
Yeah. The one thing I will say that's, I think, vitally important to get your medical staff to buy into this is that we tell them right up front, we are going to very strongly defend good care. Because the last thing your staff needs to feel is, okay, anything that happens, you're just going to lay down and write a check. And that's not what this is about. And so we tell them right up front, if we gave good care, that's what we're going to talk about, that's what we're going to say, we're going to defend good care. And they have to know that. So we go over that and kind of the training and getting the buy-in from the medical staff is they have to know that, or otherwise you're not going to get that buy-in. Question was somewhere. Dr. Yost?
So I'm interested in how the process is triggered. I heard you say that it may be triggered by a provider. I've heard you say that in at least one case it was triggered by a call from a plaintiff's attorney. Can anybody on the medical staff request that this process be initiated? And are there institutional triggers where there's something that shows up on a quality report, for example, that may trigger this?
So the question is, and I'll let Lisa start, the question is, how is this event triggered?
Sure. So all of those can trigger the event. So we've had events triggered through patient complaints coming into Heather's office. We've had them triggered by nursing leadership when they're doing rounds. We've had them triggered by providers, hospitalists who are involved on cases, just anybody who's identified something and has had a conversation with the patient saying that they're not happy and they have questions and they don't understand what's going on.
If there's an unanticipated outcome of something and nursing notifies, we start right away. We get a team together, who's involved, who's appropriate. We get up and start talking to the patient and the family. And then, like I said, some of those may turn into candor things, some may not. But the process, from our standpoint, doesn't change from the start. We get right up and talk to them right away.
And agreed, that's why the plaintiff's attorney sometimes, or into Heather's office after their discharge, we don't know about everything that's happening if it's not identified to our office, which is why I kind of like this process, because it used to be the providers would hide things and then patients would complain and then you can't talk about it. But now, even if the provider didn't talk about it, the patient does, and now we still implement it.
And the thing to me that's somewhat healthy is I'm getting more contact from other providers now that are, I was driving back from a meeting yesterday, and so we've taught all of the hospital staff is all they have to do is get on a secure texting and just type in the Candor and send it in. It will go to everyone on our team, and then we will figure it out from there. And so I get a text yesterday driving back, and it's a distraught provider saying, hey, I got a problem, I got a situation here, and we're talking about, okay, here's what we're going to do about it, and we make a plan. We're getting more of those now. That would have been unheard of, so.
And especially like some of these clinic cases, you don't know there's an unexpected outcome immediately. Sometimes it takes a while or a misdiagnosis, so you don't always get to talk to them right when the event occurs too.
Well, the call that Dr. McCoy got yesterday, the provider came to see me and was very distraught about it. How do I handle this now? What do I do? Who do I call? And by coming to me, I can say, I will take care of the risk portion of it. Let me get that process going. So be aware that whatever the event was, and we don't have enough information right now to determine if anything improper happened, or we just don't know. Patient was transferred on. I could say, let me take the risk burden now. And let me get Dr. McCoy involved to talk to that provider to talk him or her down from their level. I talked to the rest of the team and we're doing an investigation. So next week, when we have a bit more information about what went on, we can figure our next step. So it really is multidisciplinary, and as Lisa said, it could come from anywhere. Yesterday, it just happened to be from a provider.
Dr. Mr. Wayne?
When you say providers, I'll assume that you're also talking about non-physician providers.
Exactly, all providers. And the law now has been changed to include all providers. It's the Candor law. So now, before it kind of excluded some of the nursing advanced practitioners, it now includes those. So yes, I'm sorry. And the question was, does this include all providers? And yes, it does. I'm sorry.
In your institution's experience with the pilot program, I'm interested to find out what do you have in place
So the question from our psychiatrist provider friend back there is how do we take care of the caregivers, and what do we do? What's the process with that? And Teresa Colgan, whose name's on here but she's not here, is our vice president of nursing. And so if there's something to do with the nurse or seeing a certain nursing assistant or something, we usually have Teresa and then some team to help that. But any of the providers, and the thing is, we're still small enough so I know everybody really well. But yeah, so as we go through this process, I know what's going on. I'm seeing them. I'll give them a text. I'll give them a call. I'll touch base. I'll say, hey, meet me down in the doctor's lounge, and we'll have some coffee, and we're going to sort of see how you're doing. And sometimes that's all it takes. It just kind of knowing there's somebody there, all the way to I've had providers that needed immediate help that I've called one of my psychiatry friends that is sort of agreed to, hey, you need help, you call me, I help him. And he, noon that day had them over to help them. So it's just that ongoing, I know what you're going through, I'm here, call me if you need to. I don't try to talk about the clinical parts of stuff with them. When it comes to that part of things, I just sort of listen to them and try to be there. The clinical stuff is kind of separate, I think, but and so it's ongoing, and then you sort of know which ones are okay and moved on and which ones are still struggling. And then I get higher level help like you if I know the ones that are still struggling and I can't help them.
When the clinician or provider speaks to the patient, I assume that, that would be good practice. It's always the one who is directly involved with the care. You wouldn't have someone else come and speak.
So the question is, do we have the provider that provided the care try to speak to the patient? And always the team, the nurse, the physician, advanced practitioner that was involved in the care, we always try to have them be involved in it. And like I said, some of them are going to be better communicators than others, so some of them need a little more coaching than others, but absolutely, ideally, you want to have them involved in it. We've had a couple times when the patient was so upset, they didn't want that provider, and so we honored that, and we said, okay, that's fine. It's really about what they want and what's going to help. But we have had a couple occasions they said, no, I don't want Dr. So-and-so ever again to see him or her or whatever. Okay, that's fine.
Have you done any scripting? I mean, some docs are just not that great, but it's best if that person speaks to the patient. Do you give suggested language or anything how you might start out?
The question is, do we give any scripting or anything? So before any sort of a candor meeting, we kind of get together as a team and prepare, and what do we know, and what do we anticipate, and what are the sort of things we want to make sure we have answers to or don't have answers to. I meet separately with the providers, and I sit down and I kind of go through things with them before this all occurs. And like I said, the strengths or weaknesses of some of them, then you sort of have to kind of help with that. I think the scripting would be very important if we get to a point where if you're in a bigger system and you got more than one person doing this. Or if there's a time when I would be gone, we would have somebody else try to do it. But sometimes it's a real challenge. I remember during one candor meeting, I knew this provider had potential to really have trouble with this, and this could turn sour. And so I said, you're going to sit beside me. And when I sort of sense you're going in a wrong direction, I'm just going to squeeze your leg a little bit, which I had to do a couple times. But it was and he knew that. And I said, if I do that, just stop and think and be quiet and focus. And that helped direct, because you kind of don't go there. And you can see, here we go. And it's like, no, we're going to come back here. So you just have to kind of know a little bit to who you're working with. But scripting would be essential in a large organization, I think, absolutely.
Well, I could tag a little bit on that, because actually there was one that happened that Dr. McCoy was not there, and neither was Heather. And so I did meet with the provider prior to, and was a little nervous about this provider, but actually I went with, and they did a great job. They had that provider-patient trust, and I knew that the patient and the husband had that relationship with that provider for quite a long time, and they did really well. And it was a great experience for them, and so.
There's another question.
If I understand it right, the empathy within that first hour after it occurred, they call you right away when they know that an error has been made and they need to discuss it with the patient. Is that the way it works if you're on call 24/7?
Well, so if somebody, I mean, the question is, are you on call 24/7 for Candor? Well, my phone is never off, and so I can get a secure text at any time. A lot of times, if it's in the middle of the night, it's probably going to go through a nursing supervisor and potentially and then come to us. But we sort of tell staff, you know, text Candor, and we will go from there. So a lot of things, if they're, you know, fortunately a lot of surgeries or things don't happen in the middle of the night, so that really hasn't come up where we felt the need at 2 in the morning to have to immediately go to somebody. But if something happened and we did, then one of us would do that, or a couple of us would, yes.
Yeah. So I'd say it's typically that nursing supervisor just having that contact. We understand something's happened, the provider's already talked to them if there's been something at night, and it's like there will be a team tomorrow coming in to talk to you, and that has been fine so far. So they've had the empathy touch so they can relax and know that we'll take care of it.
But yes, we do try to do it right away. We had an incident of a medication overdose, and as soon as we were made aware of that, we were up to talk to the family before the patient was even really recovered from that. So we can kind of say, here's what's happened. We're going to follow this through. We're going to get all the information. We're going to try to talk to you about the things we're going to do to make sure this doesn't happen again and follow up with them through that whole process. That didn't end up being a Candor event. That was just a CRP. We're talking to you. There was really no untoward outcome other than sort of a brief ICU stay till they recovered from a wrong dose of medication. But we still were up front and let them know what happened, and their questions were answered, and they felt comfortable with that, and that was the end of it. So, one.
What if you go, one or two of you go who talks to the patient?
So the question is, who goes and talks to the patient?
Right, so Heather, you can go ahead and answer.
So if Dr. McCoy is available, he usually goes with me. Otherwise, I mean, we've gone together several times. A lot of times, though, I have gone by myself, and I just go up and I talk to them, and I tell them, I know something happened. I don't have all the details yet, and that's when I go back, telling them that I let them ask their questions, and then we go through everything, and I get them what I have, and then I just go back when I have more for them and tell them, we're going to work on it. I'm going to find out what happened, and then we'll get the details to you.
Dr. McDonald said sometimes you need a scout team, so sometimes Heather's our scout team a little bit too.
And that was what I was going to
I
say
can ask
earlier.
a lot of questions.
Yeah. When we have some of those disclosure meetings with them after they've been discharged and they're doing better, a lot of times Heather will email them back and forth and ask them questions that they have, so that way we know what they're going to come and ask us. That's helpful.
I like going in when I don't know all the details, because then I'm there asking them questions and, what happened. So then I get their side of what happened before I know anyone else's, before we've talked to anybody else. I get the patient perspective. So that helps too.
I did want to just share a few of our success stories. One of our cases that we had just a meeting. There was a small financial resolution, but it was more they just wanted to be heard. They wanted to feel that they felt the providers weren't listening to them. It was a pediatric case for the parents. And it ended up that we had the parents join our Patient and Family Advisory Council. We also had the mom and another council member came and spoke to our quarterly medical staff meeting and had them tell the medical staff what they thought patient-centered care was, which was quite interesting for them to come and speak and talk to them about that. Another one is one of our families, after the Candor meeting was finalized, they said, we love this process, we'll tell anybody about it, and that's why they're coming to speak today. And just the continued relationship with Great River. A lot of our resolutions are we're going to have you follow up with these providers for 2 years to make sure you're okay. Or we'll set you up with counseling if you're not still feeling comfortable, those types of things. So they're still in our system and we're taking care of them and they feel supported. So.
One of the things I think, and there's kind of good data to show this, but the importance of having, I think, the right people with the right skill sets as best you can. And I think a lot of us went into this not knowing if we were the right people with the right skill sets. But this was just the best we had, so this is what we did. But a lot of studies will show that when there's a disclosure event, the providers and the staff feel like it went really well. When you score that and you say, how did that, you rate that, how well did that go? And it's like 9s and 10s. I mean, we pulled this off. This was awesome. And you go back and you ask the family in a survey and you get like 4s and 5s. So you always think you're doing better, I think, than sometimes the patient and the family perceives it. So you just kind of know that going in. It's sort of like if you really think this is going well, it's like, well, don't get lulled to sleep because it might not be going as well as you think. So just always kind of keep that in the back of your mind too.
Any questions?
So I think we have like up to 10 minutes or so for questions, right, Kate? So if you do, otherwise I have a couple. Thank you.
So with this process, your Candor process as a quality improvement initiative, can you demonstrate return on investment with the process itself?
So
Describe to us how that looks.
So the question is, this is a quality improvement process initiative, and do we have any data or can we show success with that? And I'm glad you asked that question because I think the very first point is if you start this thinking our idea is this is purely a risk management thing. We're doing this because we want to save money. We're doing this because we want to lower our malpractice costs for insurance, et cetera. Okay, the data for those that have done it for a long enough period of time to collect the data have borne that out. But if you do it for that reason, you're probably not going to get, it's just going to fail. I think you have to do it for a quality process improvement initiative. That's definitely the culture change you have to try to get to. We're young enough that, so we're collecting data. We've went back and looked historically at our data leading up to where we started, and then we're collecting that to move forward because yes, we want to do the same thing and show that, but we're young enough we really don't have that yet. So, but that's our goal is to look at that and see, yes.
I would say we really didn't talk a lot about that, but in our disclosure meetings, I'd say after the clinical, the next longest section of time and questions are what are you doing to make this not happen again? And so we sit down there with the change in the plan. We'll show them a change in the policy, and the staff members that were involved come and the leaders and talk to them about how they're not going to let this happen again. So that's been a big, they really, really like that.
We don't have vials of certain doses of medications in certain Omnicells anymore because of an event that happened, and now we've changed that so that wouldn't be possible again, those sorts of things, and we just share that with them.
In terms of cost savings, though, in terms of litigation, for those cases where we have come to a resolution, the settlement amount may or may not be the same that we would have come to several years later in mediation or going to trial, but we have eliminated a lot of attorney's fees. We've eliminated a lot of time and effort by a lot of different staff who would be involved in litigation. So for those that we have had come to a resolution, we have saved a lot of money.
The average provider, I think this was 2013 or 14 data, but the average provider, it spends 11% of their time with some sort of a malpractice thing over their head, a deposition, something that's been filed and not settled or gone to trial yet. So a tenth of their life is this, and it's just miserable for them.
I would say so far our cases have been settled in 3 months, 4 months. I mean, it's very quick turnaround. Okay.
So, I'm sorry.
Question.
Yeah.
Yep.
Wondering how you get to the part, or who does the paper? You have to have the candor. I mean, I get the, having been a physician, I get the clinical part. You go in But then you have to kind of move to that next step where, well, Iowa has this law and.
So the question is, how do we go from how we would start normally to talk to patients, and how do we get the paperwork part of this privileged candor meeting? How do we initiate that?
So after we talk to the patient and then we decide it's going to be a candor case, I get all the paperwork prepared. Like I said, we use that toolkit that we obtained. We use that, made it our own, go through, have everybody sign it. There's a patient notification form, there's a patient consent, and then there's a consent by other. So everyone that's in the room signs one of the patient signs a patient one, and then everyone, including us, we all sign the consent to participate.
So that's if they're in the hospital, we will give it to them right there in the hospital. But if it's something we found out afterwards or a clinic case, then when we have our first meeting, we'll email them the papers ahead of time to read through or mail it to them, whatever their preference is, and then they just sign them the day of the meeting.
Does the clinician say, you know, we're gonna, on our next time we meet with you, we might wanna talk with you about the candor process and give them like a pamphlet or something?
So the question is, does a clinician ask them that at the time? It seems like most of the clinicians, they will just come up to us and I even in our organization, I don't know that they really know the difference much between a CRP and a candor. They just call it candor. And so they'll call up and they'll say, hey, we may have a candor event here. And then we sort of go and take care of it. And then there will be times where we may go to them and say, hey, we may want to initiate this full sort of candor process with the papers and explain what it is. When I now onboard all of our new physicians when they come, I give them the paperwork on candor and what it is and explain what it is so they sort of know now. So that's been helpful because we've gone back and tried to train everyone, and now we're onboarding them and giving them that information as they start too. So
They could broach that with the patient, you know, in their, depending how the patient is seeing.
yeah. Yes.
Are most patients accepting of this process when you send the papers, they say yes, we'll participate?
So are most of the patients accepting of the process and the papers when you send it to them?
So yes, I think so. We've had one that declined. Usually when I talk to the patient, I explain the whole process to them over the phone or in person, however they contact me or I contact them. And then we do the forms either, like Lisa said, we can email them to them, we can mail them to them, and then if it's after the fact and they're coming in for that first meeting, we'll have everybody sign then so they can review everything.
We had one event where a patient looked at the paperwork and decided they weren't comfortable signing it, and we said, okay. So, and we'll see what happens. There was a question over here.
My question is very similar to hers. It was just kind of, what's been your experience, I guess, with a typical patient or their family? When they go to sign those forms, can it feel like, oh, there's been an error and the hospital's going to have this secret side conversation and settle it with me on the side, sweep it under the rug so I don't have a big role?
Well, so the question is how do the patients see this when they kind of get hit with this paperwork, and how does that sort of go? And I think explaining to them what it is, it doesn't mean they can't get out of the process. If we go through a candor process, and I think for areas that have done this longer, the data I read last showed that less than 10%, I think the figure I saw was about 6% for places that have done this for a while, that try to have a candor event fails and it goes on to litigation. Okay, so could that still happen? Sure it could, but they sort of know you're not held to this, but if we have a resolution and it's signed, then you are, but it's just mainly that whatever is discussed in that is confidential and not discoverable.
I think it goes back to that slide of what is the goal of the patient and the family. They want the truth. They still want a relationship because they do care about their physician and other providers. So most of them, they want to have this conversation. So.
You know, the thing, and I can see Kate coming, so I know we're about ready to finish. I guess the thing that's been interesting to me of going through this now several times is I would almost challenge any of you, if you know any friends, family, colleagues that have been through a litigation, that the relationship with that patient and family was maintained. I just almost never hear of that. It's almost always severed. And it may be them, and it may be their spouse, and it may be the whole family and their extended family, and it's not just you, it's your whole hospital. And in all of these, we've maintained that relationship. And so I think that's just such a difference that you don't have to go through this whole thing. They've had these providers for a long time, and they still want to have the providers, and then they still do. That's a huge difference. So.
All right, we are about out of time, but I believe that the panelists will be around for the rest of the day, so you can catch them for any additional questions. But I want to thank everyone for